Welcome to Clinical Capsules, where we bring you the same evidence based insights you trust from TRC Healthcare, now in podcast form. We're thrilled to launch this new series as we celebrate 40 years of keeping healthcare professionals ahead of critical medication updates and guidelines. Every second and fourth Tuesday, our expert editors from Pharmacist Letter, Prescriber Insights, and Pharmacy Technicians Letter will break down the most impactful clinical developments, giving you clear, actionable takeaways in just minutes. Today, you'll hear an excerpt from our November 2024 Pharmacy Essential Updates Continuing Education webinar series. In this segment, Assistant Editor and Pharmacist Stephen Small examines the management of diabetes meds around surgery. With that, let's get started.
Now it's time to talk about perioperative diabetes medication management, or how to manage diabetes meds around planned surgeries. As our article discusses, you'll get questions about how to manage diabetes meds around surgery, partly due to rising use of SGLT2 inhibitors and GLP-1 agonists. I was surprised to find out about 1 in 5 surgery patients actually have diabetes. They may be taking multiple meds that require holding for a certain length of time before an elective procedure. Patients may need your help explaining this timing. Forgetting to space or hold certain diabetes meds can lead to procedure delays or even patient harm. And know that forgetting to restart a held med post-op can also cause complications due to undertreatment. We'll be talking about several meds today. I'll first talk about SGLT2 inhibitors such as empagliflozin, and then GLP-1 agonists like liraglutide. Then I'll go over metformin and wrap things up by talking about insulins along with sulfonylureas like glipizide, since their risks are similar. We'll talk about each med's risks, when to hold them, and when you should expect to restart them post-op to keep patients safe. Now let's use a case to start. We have Scott here, and he's 56 years old. He comes up to the pharmacy counter asking about his canagliflozin, an SGLT2 inhibitor, and exenatide, a GLP-1 agonist, for his diabetes. He tells you he has a planned hip surgery coming up in 2 weeks. His surgeon told him he would need to hold these meds beforehand, but he doesn't recall the specific timing, and he has trouble understanding his pre-op instructions. So, what questions should you ask to determine your next steps? Let's first address Scott's SGLT2 inhibitor. With these meds, we're worried about the risk of euglycemic diabetic ketoacidosis, or euglycemic DKA for short. This is serious and life-threatening. Know that euglycemia means normal glucose. In typical DKA, blood sugars are very high and uncontrolled. But in this case, it's different. The blood glucose is in a normal range. And you'll still see other symptoms of typical DKA, like nausea and vomiting or a fruity breath odor. And we can expect labs like ketones to be abnormally high too. We think this is all caused by a combination of factors. Fasting increases acidic ketones in our blood. This can worsen with SGLT2s along with stress from surgery because both of those also raise ketones. SGLT2 inhibitors also increase urination of glucose, and excessive urination can cause dehydration. So together, all of these can lead to DKA symptoms. To prevent this, the American Diabetes Association and others recommend holding most of the SGLT2 inhibitors 3 days before going to the OR. This gives the med enough time to clear from the body. Now, one exception here is ertagliflozin. It requires holding for 4 days instead because it has a longer half-life. Do this regardless of the indication. For example, still apply this to a patient taking these for heart failure instead of diabetes. So in Scott's case, we should tell him to expect to hold his canagliflozin 3 days before the procedure. Let's also give Scott some other tips to think about here. Advise watching out for some of those DKA symptoms, like nausea and fatigue. He should tell his doctor ASAP if he notices these. Keep in mind, too, some patients may want to proactively check their urine ketones at home pre-op, even if they're feeling well. But recommend they only check urine ketones if they feel unwell. These meds actually help reabsorb urine ketones in the kidney, which causes falsely low levels and could lead to some false reassurance. Post-op, you can also tell him to expect to restart his canagliflozin after he's done with all procedures, is stable, eating well, and has no other DKA risks. Let's move to Scott's GLP-1 agonist next. I'm sure you know these have become very popular, and these meds stimulate insulin release, but also slow down stomach emptying. Now, this stomach effect can help people feel full after a meal, but it can also cause nausea, vomiting, and other GI issues, including peri-op complications. For example, surgeons usually want the stomach to be empty before surgery. Otherwise, food in the stomach could be vomited during anesthesia, and the patient could choke or aspirate. These GI side effects can also be misdiagnosed as post-op ileus, where the stomach and intestine don't transport food normally. Expect patients to hold their GLP-1 agonist before surgery if they have a higher aspiration risk. The medical team and patient may use shared decision-making to talk through risks and decide whether to ultimately hold a GLP-1. Higher risk situations include patients who are still titrating up their GLP-1 dose, or if they have current symptoms of slowed gastric emptying, like abdominal pain or nausea. Having conditions that slow stomach emptying, like Parkinson's disease, can also be a risk. If the GLP-1 is decided to be held, the length of time, though, depends on how often it's dosed. Doses should be held on the day of the procedure for products given daily or twice daily, and doses should be held 1 week prior for weekly versions, like semaglutide injection. Patients with a lower aspiration risk can likely continue their GLP-1 agonist peri-op in some cases. Many patients report less GI side effects after the first month of being on a GLP-1. So for patients tolerating long-term therapy, you might see providers just take extra aspiration precautions during surgery instead of holding the GLP-1. With that in mind, let's go back to Scott. You decide to clarify with him which exenatide product he actually takes. He reports using the weekly version. You can also ask how long he's been taking it. He says it's been about 7 months without any side effects. Talking with him, he remembers he was told to hold his dose 1 week before surgery, which sounds appropriate. Pre-op, also remind patients to note the date and time of their last GLP-1 dose. Also advise they write down the date and time of their last pre-op meal. The surgery team may want this info to assess aspiration risk. And suggest bringing their home GLP-1 supply with them to use in the hospital. Hospitals are pretty unlikely to stock these because of their high cost. The GLP-1 likely won't be restarted until post-op nausea and vomiting resolve, since GLP-1s could make that worse. Missed dose guidance can also help here. It can help us determine if we need to restart the GLP-1 at a lower dose to avoid GI side effects again. For example, daily liraglutide should be restarted at a lower dose if more than 3 days have been missed. Now let's take a look at metformin, which is another very popular diabetes med. We're mostly concerned here with lactic acidosis as a peri-op complication. This is where lactic acid builds up in the body, causing symptoms like altered mental status, and it could be fatal. This can be caused by decreased metformin clearance by the kidneys, which increases metformin to toxic levels in the body. There are many things that happen around surgery that can injure the kidneys to cause this. Think about risk factors like poor PO intake, dehydration, or even renally toxic meds like contrast dyes. To avoid this, expect metformin doses to be held the morning of surgery. But there may be specific cases where doctors are okay with not stopping metformin. This includes short same-day surgeries when we can trust the patient's kidneys have adequate function and the patient has a low dehydration risk, like being NPO for just one meal. Pre-op, counsel patients to maintain adequate hydration before surgery. This can help keep their kidneys in top shape. And post-op, patients will need to be stable, eating well, and have adequate kidney function to make sure metformin clears appropriately. Now to wrap things up, let's talk about insulin and sulfonylureas. Patients' insulin needs decrease when they're fasting pre-op because their glucose intake is lower. If we give the same amount of insulin as when they're eating, we could cause hypoglycemia. And we all know dangerously low blood sugar can lead to unconsciousness, seizures, and even death. We can also apply this same idea to sulfonylureas like glipizide and glimepiride. For sulfonylureas, expect patients to hold doses the day of the procedure and while fasting. And expect the same for short-acting insulins like regular insulin or Lispro. Remember, this applies to short-acting insulins used in premix products too, like combined NPH with regular insulin. What we do with these doses can depend on the patient's glucose level, but with medium and long-acting insulins, you'll see patients generally continue these on the procedure day. Their long action makes hypoglycemia risk lower. However, their dose will be reduced. For example, Glargine might be decreased by at least 20% the night before or morning of surgery. Here are some other points you can share here with patients. Advise checking glucose more frequently while fasting, up to every 2 hours. Take this also as an opportunity with them to review hypoglycemia, its signs and symptoms, and how to treat it. After the procedures are done, their glucose will still need close monitoring. If they stay NPO or have trouble eating post-op, their insulin doses might be reduced to prevent hypoglycemia. And sulfonylureas generally can be restarted 1 or 2 days before discharge, assuming the patient is eating and drinking well. In terms of general practice pearls, pharmacists can ask to see patients' pre-op paperwork from the doctor if they have it. Spacing info might be included in there, and patients may just need your help understanding it. But we don't want to completely change a doctor's pre-op plan without them knowing. Contact their medical team if you have questions or you just need some clarity. Ask the patient if they need more home testing supplies, since they'll need to check their glucose frequently. And pharmacists, you can remind them their peri-op glucose goal is typically between 100 and 180. For technicians, you can ask the patient if they need refills for glucagon or glucose tabs in case of hypoglycemia. And we can all reinforce patients bring an updated home med list on the procedure day to help with transitions of care. Be sure to check out our resource, Perioperative Management of Diabetes Online. It lists different diabetes med classes, along with timing recommendations and other considerations to help keep our patients safe around surgery. And use our chart, Perioperative Management of Chronic Meds, to answer similar questions for ACEs, ARBs, statins, and more.
We hope you enjoyed and gained practical insights from listening to this presentation. Be sure to follow or subscribe, rate, and review this show on your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. While you're there, check out our other TRC podcasts like Medication Talk and Rumor vs. Truth. Also in the show notes, we've linked directly to a few of the excellent resources mentioned today, available to subscribers of Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights. On those websites, you'll also find a lot more evidence-based, concise, yet comprehensive resources on this and other medication therapy topics. If you aren't already a subscriber, Don't miss out on these resources. Sign up today to stay ahead with trusted insights and tools. We are an industry-leading, non-biased source of information and continuing education. And if you're a student, good news. Students can access a free version of Pharmacist Letter. We've linked to that directly in the show notes as well. Check it out. Find out more about all of our product offerings at trchealthcare.com. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Clinical Capsules.